I want you to imagine something for just a second. Picture that iconic cold metal circle of a stethoscope pressing against your bare chest.
Oh, yeah.
It's a sensation you've almost certainly experienced, sitting on a crinkly paper examination table at some point in your life.
It is a completely universal experience. We all know that sudden chill against the skin.
Right.
But while almost everyone has felt it, very few of us actually know the rich, high-stakes acoustic language that cold piece of metal is translating for the clinician on the other end of the earpieces.
And that is exactly what we are getting into today. We are looking at a stack of sources on the clinical practice of auscultation.
Auscultation, right.
By definition, from the Latin auscultare, meaning to listen attentively, auscultation is the technique of listening to internal body sounds, mostly the lungs, the heart, and the bowel, to, figure out how well your organs are functioning. And our mission in this deep dive is to explore how a 200-year-old wooden tube basically evolved into the ultimate bedside tool. We are going to map out the specific, slightly strange acoustic geography clinicians use to read your body.
Yeah, the body maps are fascinating.
They really are. And we'll also get into an intense modern debate over whether human ears are actually becoming obsolete in medicine. Okay, let's unpack this.
Synthesizing these sources reveals something fundamental about clinical medicine, I think. Understanding this one seemingly simple tool, the stethoscope, it actually provides massive insights into how medicine works at the physical bedside.
Oh, for sure.
It's not just about the equipment itself. I mean, it's about how clinicians are trained to interpret the hidden echoes in the fluid dynamics of the human body.
To understand how they listen to those echoes today, we really have to look at the surprisingly non-medical reason the stethoscope was even invented.
We do have to go back quite a bit.
Yeah, because auscultation itself is an ancient concept. The sources note that Hippocrates would literally shake his patients by the shoulders and listen for a succussion splash.
Right, to hear if there was fluid trapped in their chest cavity.
Exactly. And for centuries after that, physicians practiced what is called immediate auscultation, meaning they would just put their ear directly onto the patient's chest.
Literally skin to ear, which brings us to Paris in the year 1816. A French physician named René Théophile Hyacinthe-Laennec was treating a young woman presenting with symptoms of heart disease.
Okay.
And he ran into a very human problem. Given her age, her sex, and the strict social norms of the early 19th century, pressing his ear directly to her chest felt highly inappropriate to him.
Yeah, he was stuck.
Totally stuck. He needed to hear the mechanical function of her heart to make a diagnosis, but social propriety prevented him from doing it the traditional way.
And didn't the sources also point out that immediate auscultation was often pretty ineffective on patients carrying excess weight?
Yes, which is added to his clinical frustration.
So he needed a workaround. And he ends up having this brilliant aha moment inspired by, of all things, a children's game.
Yeah, this is my favorite part of the story.
He remembers walking through the courtyard of the Louvre and seeing kids playing with a long, solid piece of wood. One kid would scratch a pin on one end of the wood, and another kid would press their ear to the opposite end to hear the sound amplified through the solid material.
It's just basic physics.
Right. It's basically the 19th century French version of the classic 2 tin cans and a string childhood game. A literal playground physics lesson ended up revolutionizing modern medicine.
Because sound travels remarkably well through solid media, much better and faster than it does through the air. So Laennec took that acoustic principle and applied it to his patient.
By rolling up paper, right?
Yeah, he rolled a sheet of paper into a tight cylinder to bridge the physical gap between his ear and his patient's chest. And suddenly, he found he could hear her heartbeat more clearly and distinctly than he ever could with his naked ear pressed to the skin.
Wow.
He realized instantly that he was onto something massive.
And he quickly upgraded from a rolled-up piece of paper to a specially crafted hollow wooden tube. It was about 30 centimeters long, and he designed it so it could unscrew into 2 pieces to fit in his pocket.
Very practical.
Yeah, and he named it the stethoscope, drawing from the Greek stethos for chest and scopein to examine.
And then, by 1819, he publishes a foundational medical text called De l'Auscultation Médiate.
Right.
In it, he essentially maps out the acoustic landscape of the lungs and heart. He coined terms that doctors and nurses still use every single day.
Like what kind of terms?
Words like rale, rhonchus, egophony, and pectoriloquy.
Right.
I mean, he spent years correlating the acoustic sounds he heard in living patients with the physical pathology he later found during autopsies.
That's incredible dedication. But there is a bitter historical twist to his obsessive work with pulmonary diseases, isn't there?
There really is. Laennec became the world's foremost expert on diagnosing pulmonary tuberculosis by ear. He documented the exact sounds of the lung tissue breaking down. But the tragic reality of his constant exposure to the disease was that he actually contracted tuberculosis himself, dying from it at just 45 years old.
Wait, really? That is so incredibly tragic.
It is a strange twist of fate. The very tool he built to map the disease in others was the exact tool used to condemn him. His own nephew, who was also a physician, diagnosed his fatal case of TB using Laennec's original invention.
Oh, man. That is heavy. Well, we've got the physical tool in hand now, and by 1852, an American physician named George P. Kamen introduced the binaural design.
Right, the two earpieces.
Exactly, the two earpieces and the flexible rubber tubing that we instantly recognize today. But we need to look at the actual physics of why this instrument works. I mean, how do clinicians use this rubber and metal tubing to decode the most complex pump in your body, the heart?
Well, it comes down to basic acoustics and isolation. Sound is generated inside your body by physical movement, so blood turbulence rushing through valves or air moving through bronchial tubes. That sound travels as a vibration through your internal tissue and out to the surface of your skin.
Okay.
The stethoscope doesn't magically create or even dramatically amplify that sound. Its primary function is to capture and isolate it.
Isolate it from what?
The ambient noise of a busy hospital room. The earpieces seal that out, and the thick rubber tubing channels those specific frequencies directly into the clinician's ear canal without losing the acoustic energy to the surrounding air.
Which is precisely why you cannot listen through clothing.
Exactly.
The sources are very strict on this point. Even a thin, single-layer hospital gown creates a rubbing artifact against the stethoscope.
Yes, it ruins the acoustics.
Right. The fabric generates its own noise that mimics a lung problem and simultaneously dampens the high-frequency sounds coming from the body. Where you need absolute skin-to-skin contact.
You really do.
So, we've established that the tubing isolates the acoustics. But the chest piece itself isn't just a passive funnel. I always assumed the doctor just used whichever side of the stethoscope was easier to hold.
A lot of people think that. But the bell and the diaphragm are completely different instruments.
Right.
They serve entirely different acoustic purposes. The wider, flat side is the diaphragm. Clinicians press that flat surface firmly against the skin to catch high-pitched sounds, like normal breathing in the lungs or the high-frequency gurgling of bowel sounds.
Okay. And the other side?
The smaller open cup on the other side is the bell. It's designed specifically to catch very low-pitched sounds.
Oh, I see.
Yeah. In cardiology, that means listening for abnormal heart rhythms, like an S3 or S4 gallop. Mechanically, these low-pitched gallops happen when blood splashes against a stiffened or failing heart wall.
Gotcha.
But to capture that specific low frequency, you have to apply the bell very lightly to the skin.
Wait, so pushing the bell harder actually changes the tool itself. It's like stretching a loose drum skin tight, right? You accidentally turn the low-pitched bell into a high-pitched diaphragm just by pressing it too firmly against the patient's chest?
Yes, you are literally turning a bell into a diaphragm.
Oh.
If you press too hard, the patient's underlying skin stretches tight over the edges of the bell.
That makes total sense.
And that taut skin acts just like the plastic diaphragm, automatically filtering out the exact low-frequency splashes and rumbles you are trying to catch. It requires a surprising amount of physical finesse.
Which brings us to how clinicians actually navigate the chest. When a nurse or doctor listens to your heart, they aren't just roaming around randomly hoping to hear something.
Oh, definitely not.
They follow a highly specific sequence of 5 landmarks. Nursing and medical students memorize this sequence with the mnemonic APE to man.
Right, APE to man. Let's break down those landmarks. Aortic, pulmonic, Erb's point, tricuspid, and mitral.
Okay.
And what's fascinating here is that these 5 designated spots on your chest do not actually line up with where those heart valves sit anatomically.
Oh, wow. I did not know that.
Yeah, you aren't placing the stethoscope directly over the physical valve. You were listening downstream.
Downstream.
Yes. You place the stethoscope in the specific spots where the fluid dynamics of the blood carry the sound of the closing valve the loudest. Auscultation is about tracing the echoes of the body's plumbing, relying on the direction of blood flow, rather than just looking at a static anatomical map.
That distinction makes so much sense. You have to go where the water carries the sound, not where the rock was dropped.
Beautifully put.
And at each of those downstream spots, they are listening for the classic lub-dub of a heartbeat. Let's get into the mechanics of that sound.
Let's do it.
The lub is S1, right? The start of systole.
Correct.
That is the moment the heart muscle actively squeezes and pumps blood out to the body, snapping the mitral and tricuspid entry valves violently shut. That snap is the lub.
Yep. And the dub is S2, the start of diastole. That's when the heart muscle relaxes to fill back up with blood, snapping the aortic and pulmonic exit valves shut to prevent backflow.
But beyond the clean lub-dub, they are also listening for murmurs, which indicate turbulent blood flow. The sources outline how they grade the severity of those murmurs on the Levine scale, from Roman numeral 1 to 6.
Right, and the Levine scale perfectly illustrates the immense physical power of sound waves inside the human body.
Oh, so?
Well, a grade 1 murmur is so faint that even an expert cardiologist in a perfectly silent room might miss it. It takes extreme concentration.
Okay.
But by the time you reach a grade 4 murmur, the sound is so loud and the turbulence is so violent that it creates a thrill.
A thrill.
Yeah, thrill is a palpable vibration. You can actually feel the heart vibrating against your hand if you place your palm flat on the patient's chest.
Oh, wow.
And a grade 6 murmur is so severe, generating so much acoustic energy, that you can hear it without the stethoscope even touching the skin.
That is wild. Heard without even touching the skin.
It really shows you how powerful the heart is.
Well, the heart gives us a very centralized, predictable rhythm to track. The challenge changes completely when clinicians move to the lungs and the abdomen, right?
Absolutely.
Because they're dealing with massive real estate. The physical technique shifts entirely, and we also start to see some surprising flaws in how medicine has traditionally been practiced.
Moving to the lungs is a great example of this spatial challenge. I mean, you're listening over a huge area of tissue, both on the front of the chest and across the back.
Right.
Nurses are trained to distinguish 3 distinct normal breath sounds, purely based on where they are heard: vesicular, bronchovesicular, and bronchial.
Can you break those down?
Sure. Vesicular sounds are soft, low-pitched, and rustling. Often compared to wind blowing through leaves, you hear these over the vast periphery of the lung.
Okay, so way out at the edges.
Exactly. Bronchial sounds, on the other hand, are loud, harsh, and high-pitched. You normally only hear those right up over the trachea in your neck, where the air pipe is large and hollow.
Here's where it gets really interesting because, well, the diagnostic trick with the lungs isn't necessarily finding a broken sound. It's finding a normal sound in the wrong place.
Exactly right.
If a clinician hears that loud, harsh, high-pitched bronchial sound way out in the peripheral lung fields, like at the bottom of the ribs, that suggests a condition called consolidation.
Right, consolidation.
Mechanically, it means the normally airy lung tissue has become dense and fluid-filled, like with a severe case of pneumonia.
Yes.
And because sound travels better through fluid and solid mass than it does through air, that dense tissue transmits the loud sound from the windpipe perfectly down to the bottom of the lung.
That's the physics again.
Right. It's like hearing a kitchen blender running in the master bedroom, you know? The sound itself isn't broken, but its location tells you something is structurally very wrong with the house.
That is a perfect analogy.
Yeah.
And beyond displaced sounds, clinicians are listening intently for adventitious or abnormal sounds. These provide incredible clues about what is happening on a microscopic level.
Like crackles and wheezes.
Right. You have crackles, sometimes called rales, which are generated when fluid-filled or collapsed airways violently pop open during a breath.
What does that sound like?
Fine crackles literally sound like rolling strands of hair between your fingers right next to your ear.
Oh, wow. Okay.
And coarse crackles sound wetter, bubbling, and louder. Then you have wheezes, which are continuous musical whistling sounds caused by air squeezing through narrowed airways.
Which is the classic hallmark of asthma, right?
Exactly. Raunchies are lower-pitched, snoring sounds indicating thick mucus in the larger airways. And finally, the pleural friction rub.
A friction rub.
Yeah, this sounds like creaking leather or walking on fresh, dry snow. It is caused by the inflamed linings of the lung physically rubbing against the chest wall with every breath.
It's just an incredibly descriptive acoustic language. They even utilize something called the auscultatory triangle on your back, right?
Yeah, the triangle.
It's this specific little muscle-free zone between your shoulder blade and your spine. It acts as the perfect acoustic window into the lungs because there's simply less back muscle and tissue in the way to muffle the breath sounds.
It's a great spot to listen.
But moving down the body to the gut, this is where medical tradition starts clashing hard with modern evidence. When they examine the abdomen, the strict golden rule is sequence: inspection, auscultation, percussion, palpation. You absolutely have to look, then listen, before you press or tap on the stomach.
The mechanics demand that sequence.
Yeah.
If you press on the stomach first with your hands, you physically stimulate the intestines.
Right, you mess up the baseline.
Exactly. You
Yeah.
artificially create bowel sounds by moving the tissue around. So auscultation must come first to get an accurate baseline. You're listening for organic clicks and gurgles, which normally happen about 5 to 30 times a minute. But here is the major point of friction highlighted in the sources. For decades, nursing and medical schools universally taught this sacred ritual. If you suspect a patient has a bowel obstruction, you must listen to the abdomen for a full 5 minutes before officially declaring bowel sounds absent.
5 minutes. But if they are just standing there listening to silence for 5 whole minutes, what exactly are they waiting to hear? Does the data actually support that this time investment yields a reliable diagnosis?
Well, that's the thing. The research says it's basically a massive myth.
Really?
The clinical data shows it is highly unreliable. Studies demonstrate that if you have 3 different clinicians listen to the exact same patient's abdomen, they will frequently disagree on the interpretation.
Wow.
Yeah. One might call the sounds normal, another hyperactive, and the third might declare them absent. Furthermore, the sounds they do agree on correlate very poorly with actual verifiable pathology, like a true mechanical bowel obstruction.
So why do they still do it?
The 5-minute rule is a traditional ritual. It persists mostly because standing at the bedside for 5 minutes feels culturally authoritative. It demonstrates care to the patient and, it is completely non-invasive. But the rigorous evidence base for it being a diagnostic tool is remarkably thin.
If our brains can essentially trick us into misinterpreting bowel sounds during a 5-minute exam, it forces an uncomfortable question about human perception in general.
It really does.
I mean, just how reliable are human ears when the stakes are even higher, like with cardiac events? The sources highlight a sobering study from 1997 by Mangione and Niemann, published in JAMA.
Oh, the study's a big one.
They tested hundreds of internal medicine and family practice residents by playing them high-quality audio recordings of classic textbook cardiac events, like the various murmurs and gallops we discussed earlier.
Right.
And the accuracy was staggering. These trained residents correctly identified the classic sounds only about 20% of the time, 1 in 5.
That specific data point shook the medical education world because it exposed a pervasive misconception.
Which was?
Historically, there was an assumption that auscultation was a passive skill. People assumed you just put the earpieces in, placed the bell on the chest, and the sound simply handed you the diagnosis.
But the study proved otherwise.
Exactly. The Mangione study proved that auscultation has a steep, highly measurable learning curve. It is an active cognitive skill requiring intense, deliberate practice.
You can't just pick it up on the fly.
No. You cannot passively absorb it just by walking around on ward rounds. This is why modern medical and nursing programs now use highly advanced digital mannequins that can replicate specific murmurs.
Oh, that's cool.
Yeah, and they use vast audio libraries to train clinicians to recognize these acoustic patterns before they ever touch a real patient.
But hearing that 20% accuracy rate, does this mean for a lot of practicing clinicians, the stethoscope is secretly just a prop?
It's a harsh question, but people are asking it.
Are they just wearing it around their necks for authority? Because this brings up the huge modern debate in the sources over point-of-care ultrasound, commonly called POCUS.
If we connect this to the bigger picture, medicine is currently locked in a struggle to balance the hyper-precision of modern visualization technology with the immediacy and accessibility of, traditional bedside acoustic skills. Prominent cardiologists like Jagat Narula are arguing forcefully that handheld ultrasounds should be declared the modern stethoscope.
And their argument makes sense, right?
And their argument is entirely logical. Why strain your ears to infer what is happening through a muffled subjective acoustic echo when you can hold a small probe against the chest and literally watch the heart valves closing on a high-definition smartphone screen in real time?
It's hard to argue with seeing the actual physical mechanics, but the traditionalists are pushing back hard against replacing the stethoscope.
Oh, they are.
They argue that acoustic auscultation is incredibly fast, it's virtually free once you own the tool, it doesn't need a battery charge, there are no software updates to run, and most importantly, it builds vital clinical intuition.
Right. And nursing, in particular, seems to be the primary stronghold for the traditional acoustic stethoscope.
Why is that?
Consider a hospital nurse's daily workflow. They perform serial reassessments on multiple patients throughout a 12-hour shift.
Okay, constantly checking in.
Right. A stethoscope is the only diagnostic tool that fits easily in a scrub pocket, requires absolutely zero prep time or boot-up sequence, and allows a nurse to instantly catch subtle changes in a patient's respiratory or cardiac condition right at the bedside.
Whether it's high noon or 3 in the morning.
Exactly. While an ultrasound gives a better picture, it isn't always sitting in the room ready to go the second a patient starts struggling to breathe.
So what does this all mean for you, the listener, the next time you are sitting on that exam table and feel that cold metal circle press against your chest?
Great question to ask.
It means you are participating in a 200-year-old tradition that remains the fastest, cheapest diagnostic tool on Earth. A nurse hearing new, wet crackles in your lungs can flag fluid overload or pneumonia hours before an X-ray machine is ever ordered.
It saves lives.
A new grade 3 murmur picked up during a routine physical can trigger life-saving cardiology interventions. And in global health settings or resource-limited clinics where expensive ultrasound machines simply don't exist, Lennox's centuries-old acoustic technology is still the most advanced, vital piece of equipment in the room.
It is a remarkable testament to the power of human perception and physical acoustics. Even acknowledging its documented flaws and, the steep learning curve, the stethoscope remains the immediate, unbroken bridge between the patient's internal physiology and the clinician's analytical brain.
But I want to leave you with one final thought to mull over, building on where we are headed next. The sources briefly mention modern electronic stethoscopes that can digitize, amplify, and record acoustic signals.
They are becoming more common.
But what happens when artificial intelligence is integrated directly into those digital devices?
Oh, wow.
If an AI algorithm inside the earpiece eventually does the listening and interpreting for us, confirming the diagnosis with perfect accuracy in real time, will the human clinician finally lose that hard-earned acoustic intuition that René Laennec first discovered in Paris 2 centuries ago?
That is the ultimate question for the future of bedside medicine. I mean, the cold metal circle isn't going anywhere, but whether it's a fallible human ear or a flawless algorithm interpreting the echoes, that is the next great frontier.